An acute variceal hemorrhage is a rapid, life-threatening emergency. You are fighting against extreme physical pressure inside a failing vessel, and every minute lost significantly reduces the patient's chance of survival. Managing this crisis requires a precise step-by-step protocol. We are going to walk through the exact framework required to stabilize a patient, from the moment they arrive in the emergency bay through their post-procedure recovery. Step 1 is securing the clinical prerequisites. Before any intervention begins, you need a suspected upper GI bleed, continuous hemodynamic monitoring, and 2 large-bore IVs. Here is the most critical operational rule of this phase. Initiate your treatment based entirely on clinical suspicion. Do not wait for endoscopic confirmation to start pharmacotherapy. Taking immediate, protocol-driven action prevents irreversible hemodynamic collapse before the patient ever reaches diagnostic imaging. With lines secured, begin volume resuscitation using crystalloids. Research shows that colloids offer no clinical advantage over crystalloids in this setting, so exclude them from your immediate response. Next, implement a restrictive transfusion strategy. You must hold off on transfusing red blood cells until the patient's hemoglobin drops below 7 grams per deciliter. This visual gauge highlights your post-transfusion target, a safety zone of 7 to 9 grams per deciliter. Aim for stabilization, not normalization. Pushing past that green zone into overtransfusion spikes portal pressure, creating a feedback loop that actively worsens the bleeding. Simultaneously, start vasoactive drugs immediately. Choose Terlipressin, Somatostatin, or Octreotide to reduce splanchnic blood flow, and pair it with prophylactic ceftriaxone to prevent bacterial infection. Before moving to mechanical intervention, administer 250 milligrams of intravenous erythromycin 30 to 120 minutes prior to endoscopy. This acts as a prokinetic agent, clearing blood from the stomach to give the endoscopist a clear field of view. By combining precise fluid limits with immediate pharmacotherapy, you halt the bleeding feedback loop at a physiological level before any physical tools are deployed. Once the patient is hemodynamically resuscitated, the clock is ticking. You have a strict 12-hour maximum window to perform the endoscopy. If you locate esophageal varices, the definitive treatment pathway is straightforward. Endoscopic band ligation, or EBL, is your treatment of choice. For gastric varices, use a different approach. Left, esophageal varices are banded. Right, cardiofundal varices receive cyanoacrylate glue injection for lower rebleeding rates. Caution: applying bands to wide gastric varices causes them to slip off, leaving a massive ulcer and triggering severe rebleeding. Cyanoacrylate is highly effective, but it is not readily available in most U.S. centers. If you lack access to the glue, you must consider early TIPS placement as your primary alternative for gastric varices. The anatomical location of the varix strictly dictates the mechanical tool you use. Applying the wrong tool will instantly transform a successful stabilization into a fatal secondary bleed. Even with successful endoscopic treatment, you must evaluate high-risk patients for preemptive, early TIPS placement within a 24 to 72-hour window. This checklist outlines the specific triggers for escalation. If your patient is child PUC, or if they are child PUB with a MELD score over 7 and active bleeding, they require an early TIPS consult. If bleeding persists despite your initial protocol, deploy balloon tamponade. Keep in mind, this is strictly a temporary physiological bridge and must be removed within 24 hours. Hardware selection here is critical. Use a Sangstack in Blackmore or a Minnesota tube for esophageal varices, and a Linton Naclas tube for gastric varices. While the balloon tamponade holds the line, prepare your definitive rescue therapy. This means moving to urgent TIPS, or for uncontrolled gastric varices, utilizing BRTO. Rescue therapies and early TIPS function as pre-planned escalating safety nets for patients whose physiology resists standard hemostasis. After securing hemostasis, maintain your pharmacological defense. Continue the vasoactive drugs for exactly 5 days post-procedure, and run the prophylactic antibiotics for a full 7 days. Next, initiate early enteral feeding. Once the patient is stabilized, getting nutrition into the gut supports systemic recovery and maintains mucosal integrity. There is one major pharmacological contraindication to observe during this acute phase: non-selective beta blockers, or NSBBs. Continuing NSBBs in a patient who is hypotensive, meaning a systolic blood pressure below 90 millimeters of mercury, will strip away their compensatory mechanisms and trigger severe adverse outcomes. The acute emergency phase only truly concludes when the 5-day pharmacological window closes, without a rebleeding event or a hypotensive crisis. This monitor reflects successful execution of the protocol. By maintaining strict hemodynamic thresholds, selecting the right tools, and managing risk variables, you stabilize the patient. Only after the patient fully recovers from this acute episode do you transition to secondary prophylaxis. Long-term prevention requires combination therapy. You will pair NSSBBs with repeat endoscopic band ligation sessions, scheduling them every 1 to 4 weeks until the varices are entirely eradicated. When selecting your NSSBB, carvedilol offers a distinct advantage. Its dual alpha-1 and beta blockade provides a superior reduction in portal pressure compared to traditional beta blockers like propranolol. Mastering management of an acute variceal bleed means navigating a continuous spectrum of care, moving methodically from immediate aggressive resuscitation to calculated long-term variceal